Good evening. Welcome you all to the next edition of this monthly meeting of Tamil Nadu ISG. I welcome you all to this. Apart from the monthly session, this is a very important part because this is the third GF Journal anniversary celebration as well. We hope to see more people joining in soon. So it's almost 3 years of complete successful publication of our own journal, and we'll be stepping into the 4th year as well now. So to start off, I request our President, Dr. Epan, to give a welcome address, and then we move on to the next, please. Thanks.
Good evening, friends. Welcome to this month's edition of the TNIC monthly meeting. So may I take the opportunity to spend a few minutes on some lateral thinking. So this is when an organ fails in acute inflammation, this could be considered a clogging of a filter inside the organ. And this is a bit like a traffic jam which happened in the Suez Canal. So let me explain what I mean. So as I was preparing for this today morning in my department, I came across this MCQ. I don't know whether it was a school children or it's for MBBS NEET or post-MBBS NEET. The question is, which organ filters blood in the human body? So, and the website is also given there, it's topper.com. So I may say I didn't agree with the answer. So the answer they said was spleen. But to me, liver is also a filter. So when you think of it, it's a question of now, what do you call a filter in plain English language? Okay. So I see some of you got the answer correct, but I disagree with the answer. So I'm saying, what is a filter? So a filter refers to, it's an English term only. It's you're filtering some fluid through one filter paper. You know, you can think of it like that. It can be anything. Of course, it's the kidney which produces urine, and the liver, some bile comes out. So there are different ways of interpreting it. Now, of course, it all revolves around plasma exchange. So increasingly, Plex is saving more lives, and it's now getting more and more evidence. Very clear now that in acute inflammation and organ failure, for example, in severe alcoholic hepatitis, the survival is now getting to be good. And we think in acute liver failure, it's all like on traffic jam. All the inflammatory cells and debris are coming into the microcirculation, and the flow of traffic is getting jammed up. And then the organ is failing because of lack of perfusion of the organ. And this treatment of plasma exchange with low dose steroid is allowing that traffic jam to get resolved. It seems to have an anti-inflammatory effect. So every organ in our body has got capillaries or sinusoids. We can call it like a filter. And clogging of this microcirculatory filter can impede the flow of traffic, that's the flow of blood, and cause dysfunction or failure of the organ. Now the location of this traffic jam matters, which part of the body. And so if a vital organ is clogged, the filter is clogged, it can lead to immediate death. That's why it's called a vital organ. And this treatment of Plex plus low dose steroid has an anti-inflammatory effect. So that comes to Suez Canal. So some of us may be aware that in the year 2021, one very large ship blocked the Suez Canal. The Suez Canal is the way through which more than 10% of the world's trade goes through. And for 21 days or so, it was blocked. So it became a big problem. And in fact, this particular vessel is 400 meters long. It's a massive vessel, and it caused a big problem. And a NASA satellite picture shows that the number of ships waiting to cross this always became ever so many kilometers. It's a huge problem. Now this possibly is what's happening in the liver and maybe in other organs in the body in these syndromes. And they brought in some way of doing, you can see them doing plasma exchange. Some way they are unclogging the clogged filter, and then the Suez Canal started flowing again. Okay? This is true. The rest of it is only conjecture, but this really happened. Now this also happened in Panama Canal. There's yet another canal where it's in America, where the problem is not mega ship, it's actually lack of water. climate change and drought, and now Panama Canal is not functioning well. So yet another filter is getting blocked. So in different parts of the world, when a vital organ or an important organ, vital organ are referred to some which cause immediate death, but some important organ in the body, if there is clogging of the filter by acute inflammation, then such treatments may work. Now, this is a report just come out in press. Though the pancreas guys here may be interested, though I am a liver person, where I think there are 7 or 8 patients in the series who had acute pancreatitis and again had a microcirculatory problem. Okay, they met criteria for secondary thrombotic microangiopathy, and they all survived with plasma exchange with low dose steroid. So I'm saying this term about this filter is applicable to all organs in the body. I'm using a generic interpretation of filter, and this concept allows us one more therapeutic avenue. The question is to work out, is it applicable or not? So this is my last slide. So we are changing the what we wrote that time. Traffic jam in any organ with acute inflammation causes organ dysfunction, organ failure. And the anti-inflammatory effect of low volume Plex and low dose steroid can help clear the traffic jam. Thank you.
Thank you, sir. It's always food for thought for, you always come with some interesting facts and food for thought. Now we move on to the postgraduate session. I will request the chairpersons, Dr. T.K. Anand, Dr. Satya, and Dr. Shubha. Dr. Mahadevan is not able to meet, so I'll request Dr. Vinod also to take the chair and conduct the proceedings, please.
Good afternoon. I'm Dr. Anand, consultant in Apollo Hospitals.
Dr. Shubha, Assistant Professor in MMC. Medical Gastroenterology.
I'm Dr. Satya, Assistant Professor in Stanley Medical College.
I'm Dr. Vinod Kumar, consultant GEM Hospitals.
There are 3, I think, interesting cases and review literature. So first, I'll call upon Dr. Nitin Ramesh from MMC to give the presentation.
Very good evening to one and all. I'm Dr. Nitin Ramesh, second year resident in Madras Medical College. Here we are presenting an interesting case of dysphagia. So our patient was a 68-year-old female who was working as a factory worker in textile industry in Karur, and she was admitted on 21st of October. So this patient has a past history of corrosive acid ingestion, which was used as a coloring agent in threads in the factory where she was working. That happened in 1984, after which she developed post-corrosive stricture. And in 1991, 4th of May, coloplasty was done, and after that the coloplasty underwent necrosis the next day. Then on around 5 months later, gastric pull-up and feeding gynostomy was done. Then she was gastric pull-up was done in Professor Rangabhasham sir's unit, which was famous for esophagus reconstructive procedures in corrosive injury patients. And in 2004, the patient developed first anastomotic side stricture, after which multiple dilatations were done, and last one was done on 30th of September 2021. And now the patient presented with us to us with a history of progressive difficulty in swallowing of solids more than liquids since the last 10 days. There was history of loss of weight and loss of appetite, and also constipation. There was no history of rhinophagia, hoarseness of voice, or cough. There was no history of neck swelling or chest pain, no history of any GI bleeding manifestations. Personal history, she had a mixed diet, there were no addictions, but there was low consumption of fruits and vegetables, and sleep and appetite was normal, bladder habits were normal. Family history was also insignificant. She belonged to a low socioeconomic class. On examination, patient was conscious oriented, moderately built and poorly nourished. There was pallor. There was no icterus, cyanosis, clubbing, pedal edema or lymphadenopathy. There was a linear scar seen on the left side of neck. Breast and thyroid were normal. There was no cutaneous signs of internal malignancy. Patient's weight was 35, height 140 centimeter with a low BMI of 17.8. Vitals were stable. Pulse rate was 80 per minute, normal in volume, regular. and BP was 110 or 80 millimeters of mercury. Coming to per-abdominal examination, there was a midline scar seen. Abdomen was soft, non-tender, no hepatosplenomegaly. Bowel sounds were present, no guarding or rigidity. Other systems were within normal limits. Coming to the investigations, the patient was having anemia on CBC, and later peripherals may reveal that it was microcytic hypochromic anemia. LFT and RFT were normal. Serum calcium level was normal, and all the viral markers were negative. USG abdomen was also normal. This is the chest X-ray of the patient. You can see the gastric conduit in the chest X-ray. And upper GI endoscopy was done, which showed ulceroproliferative growth at 14 centimeter with luminal narrowing. So scope could not be passed beyond, and biopsy was taken. Then CT chest revealed that there was suspicious diffuse circumferential heterogeneously enhancing wall thickening in the cervical esophagus of a length 7.8 centimeter with a maximum thickness of 1.7 centimeter, extending from the upper border of cricoid cartilage to the upper border of left brachiocephalic vein. There was loss of air plane between the lumen and left lobe of thyroid cartilage, cricoid cartilage, trachea, and left brachiocephalic vein. This is a sagittal section. You can see the green arrow is showing the growth, while the orange arrow is showing the gastric pull-through. This is first one is a coronal section. This the green arrow indicate the esophageal growth, and here also you can see heterogeneously enhancing growth in the esophagus, which is shifting the trachea laterally. This is a lateral image which is showing the remnant esophagus. The orange arrows indicate the remnant esophagus. Then in procedures done, we did a dilatation under fluoroscopy from 9 to 12.8 millimeters, and relook OGD showed an ulceroproliferative growth from 14 to 22 centimeter with luminal narrowing, and anastomotic site was at 22 centimeter, and stomach capacity was reduced. And finally, histopathological examination showed that it was an infiltrating squamous cell carcinoma, which was moderately differentiated. This is the endoscopic video. We are coming back from the duodenum. This is the gastric conduit. This is the anastomotic site. Above which the growth can be seen. So these are the images. So you can see the this is ulceroproliferative growth. It's an anastomotic site, and this is a gastric conduit. So the diagnosis: our patient has a history of corrosive acid ingestion 39 years back, after which she developed post-corrosive stricture, after which coloplasty was done, and which underwent necrosis. Then 6 months later, gastric pull-up was done, and she developed anastomotic site stricture, followed by multiple dilatations, and now the diagnosis is CA esophagus, which is infiltrating squamous cell carcinoma, which was moderately differentiated. So coming to the review of literature, so this is one case which was presented in International Journal of Surgery in Greece. So this case was a case of acid injury. Usually the most common cases which are in the literature are following alkali injury, but this case is as acidic injury, similar to our case. And this patient presented after 35 years of acid injury, but our patient presented with more than 39 years. So our case presented later than this case. And in this case, so they are telling that this is the first such report published in the literature. In this case, they had done a near total esophagogastrectomy followed by coloplasty, right-sided coloplasty. In our case, first a coloplasty was done, which got necrosed, and after that, we did a gastric pull-through. So this is another report which was published by Kochar sir in India. They reported 3 cases, but all of those 3 patients presented less than 30 years. Our case is much older than all these cases. And in one of these cases, they had jejunal interposition. Other 3 cases were not operated. So risk factors in this patient. This patient is having history of low consumption of fruits and vegetables. Then she was from a low socioeconomic class, and she used to have high temperature food like tea and coffee. Then we cannot tell this is lye because lye means alkali. Our patient had acid. This is another study which was published, taken in JIPMER. They studied 105 patients over 30 years, and in this study they found 2 patients who developed CA esophagus. But they did not mention how many years after the acid ingestion the cancer developed. A few words about corrosive strictures leading to CA esophagus. It was first described in 1904 by Teleki, and it is said that esophageal neoplasms, both adeno and squamous carcinoma, develop 1,000 to 3,000 times more when there is a history of caustic injury. And incidence is 2 to 30%, and latent periods is from 1 to 3 decades after ingestion. And the risk of cancer is 700 to 800 per 1 million person years. Compared to in the prognosis, these patients have a better prognosis compared to the routine CA esophagus cases, because they have this injury at a younger age and they present early because already the esophagus is narrowed, and the long-term follow-up is there because patient keeps on coming for dilatations. And another thing is that this stricture is surrounded by scar tissue, which will prevent dissemination. And also the lymphatic veins may be destroyed, which will prevent lymphatic spread. So diagnostic test, upper endoscopy is done, upper GI endoscopy. We are doing the acute phase, ideally within 48 hours. And some studies are telling that up to 96 hours we can do to assess the lesion and the depth of the lesion. Then in chronic phase, which is important in our patient, there is no consensus on minimum time interval between endoscopic exams. So some studies are telling that we should follow up from 10 to 20 years after caustic ingestion, and every 2 to 3 yearly interval. But we don't have a proper consensus or guidelines. And this is the Zarkar classification, which was first published in 1991. And endoscopy is the gold standard for diagnosing dysplasia and early squamous cell carcinoma, but it is expensive for the healthcare system. So while doing endoscopy, we should do careful examination of the narrowing and strictures to search for pre-neoplastic lesions. Then Lugol's iodine and chromoendoscopy versus NBI enhanced endoscopy. Lugol's iodine chromoendoscopy is considered the gold standard for screening for CA esophagus, but now in most of the centers NBI is replacing it. And CT can be done to evaluate relationship between esophagus, airway and abdominal cavity. MRI doesn't offer any advantage. Bronchoscopy may be done to assess invasion to trachea and bronchi. And colonoscopy may be done if we have to assess for doing coloplasty. This is one recent study done in 2020. It was a study done in Brazil. This was done specifically in children who had history of corrosive ingestion, and they took the miRNA, and they divided into 2 groups. One group was followed up less than 5 years, and the group B was followed up more than 5 years. So they found that these 2 miRNA 374 and 574 were dysregulated in patients who had history of corrosive injury, and this may help in early diagnosis in the future. So future perspectives, what is lacking? We don't have proper guidelines for screening malignancy in post-corrosive injury, and we should give patient education, counseling and follow-up. And we should establish in MMC we are seeing daily we are seeing a lot of corrosive patients, and a lot of patients among these patients may develop into cancer in the next 3 to 4 decades. So we should form a database to prevent this occurrence and for early diagnosis. And now potential biomarkers are also there, which we should work upon. Thank you.
Nicely presented, Nitin. There are, in this patient, I think there are 2 obvious risk factors. One is the corrosive injury and the gastric pull-through.
Yes,
The thing is this different from, prognostically, is it different from a de novo CA esophagus, or is it the same?
So
And
corrosive
what
injuries,
was done for the patient?
a corrosive injury happens at a rate of 10,000, 1,000 to 3,000 times more than the normal routine CA esophagus. So we have not followed, we don't have proper guidelines for following these patients. So the need of the hour is we should establish guidelines to prevent such occurrence, because we are daily having a lot of cases of corrosive injury. Yes, sir. Actually, these corrosion-induced strictures, they have better prognosis compared to other. The mortality is lesser than the routine de novo esophagus, because the spread is less, metastasis is less, lymphatics are gone. Prognosis.
You cannot distinguish whether it's de novo as a cancer risk or is it due to corrosive. That's what we're asking. So we know the risk is high.
Yes,
We
ma'am.
do not know whether it's just a regular esophageal cancer. The duration of illness is only 10 days. Huh? How many days was it?
Rapidly progressing dysphagia of 10 days, ma'am.
How is it possible? 10 days, such a big growth. That means somewhere the history is wrong, no? It's not an acute dysphagia. I thought it was a foreign body impaction. 10 days is too short. That means it's more of an extrinsic compression that's causing the dysphagia. It's not intraluminal.
Yes, ma'am.
10 days is too short. This particular patient with a huge, such a big mass, somewhere the history is missing there.
But maybe, ma'am, because this patient was having history of corrosive injury, they will be already they might be having a little small amount of dysphagia. So
No. This is a bypass that is going through the stomach. No, there's no question of the esophagus here.
yes, ma'am.
Is there any distinction between light stricture surgery done and acid ingestion in terms of the incidence of cancer?
Sir, actually, I couldn't find any studies like that. But most of the CA esophagus after corrosive were seen in alkali ingestion patients, sir. Acid were very less patients.
So, what have you done for this patient? If you added the treatment which you have done, it would be more interesting, right? Have you done since it's a squamous cell, have you done a radiotherapy? Have you put a stent or a Riles tube for?
Sir, we have presented this case in the tumor board, and we have decided to go forward with concurrent chemoradiation therapy. But PET scan is awaited, sir. After that, we will plan for chemoradiation therapy. First we have to stage after doing the chemoradiotherapy. After that, we will decide regarding the surgery if feasible. Based on that staging.
Okay, thank you.